Good morning. I'm Dr. Saimini Gunawardena, Registrar in Medicine attached to University Medical Unit, Teaching Hospital, Karapitiya, and a former Senior House Officer at DGH Monaragala. The door-to-needle time and thrombolysis outcome with tissue plasminogen activator in acute ischemic strokes in District General Hospital Monaragala. This was a retrospective audit which was carried on patients whom we thrombolyzed within the first year of treatment protocol introduction from March 2020 to March 2021. Stroke is a leading cause of disability globally. The best practice for acute ischemic stroke management includes thrombolysis with tissue plasminogen activator, alteplase, within the golden window period of 4.5 hours. And the tissue plasminogen activator, compared with no reperfusion therapy, improves short-term as well as long-term outcomes. And the door-to-needle time is the time taken from the admission of a patient to the time of intravenous thrombolysis. And according to the current evidence given by the recent clinical trials, the shorter the door-to-needle time, better the outcome of thrombolyzed patients. And the expected door-to-needle time that is to be achieved is less than 60 minutes in 75% of thrombolyzed patients in a center, according to the current recommended standards given by the American Heart Association. And this summarizes the annual statistics of stroke patients from 2018 to 2020 at DGH Monaragala. As you can see, it clearly demonstrates the stroke burden that our hospital had to carry, as it is the main referral center in the district and also the only hospital which has CT facilities available in the district. And treatment protocol for thrombolysis of acute ischemic stroke was introduced to DGH Monaragala in March 2020. Prior to initiation of this process, several workshops and educational programs were organized in order to train the health staff, including the medical officers, nursing officers, and the paramedics, in order to impart the theoretical knowledge as well as to emphasize on the practical skills in order to minimize the delay. At the same time, a stroke protocol booklet was developed based on the current stroke guidelines, and it was kept at TTU for the reference of the health staff. And whenever a patient is encountered with an acute ischemic stroke being a candidate for thrombolysis, his or her data was included in this booklet. So after 1 year from the initiation of this thrombolytic protocol, we wanted to assess whether our stroke care services were meeting the standard recommended standards in the world. So we carried out a retrospective clinical audit by obtaining data from this stroke protocol booklets, the ETU notes, the bedhead tickets, and the 3-month clinic follow-up notes of the patients whom received thrombolysis within this 1 year period. All the patients who was thrombolyzed among the acute ischemic stroke patients were included in this audit. In this, NIHSS, which was documented on admission, was used to assess the severity of ischemic stroke. And in this clinical audit, we used 2 parameters to evaluate our stroke care services. The first one, the door-to-needle time, and the second one, outcome of the patient. We considered 2 main outcomes for the patients: the level of disability or the dependence, and whether the patient has developed any hemorrhages as a complication to the thrombolytic therapy. So the documented modified Barthel index value at discharge and at 3 months clinic follow-up was used to measure the disability or the dependence level. And the ECAS classification was used to decide whether the occurred intracranial hemorrhage was symptomatic, causing mass effect, and was it causing any effect on the final outcome. So in the results of this clinical audit, we found out a total of 14 patients received thrombolysis within the first year. And we thrombolyzed our very first patient on the 27th of March 2020 at the very beginning of the COVID pandemic. And all these patients had NIHSS ranging from 6 to 16, falls under moderate to severe strokes. And this clinical audit revealed door-to-needle time of all patients was between 65 to 165 minutes, with the median being at 85 minutes and the interquartile range from 73 to 118 minutes. And the minimum door-to-needle time noted was 65 minutes. As you can see, this box and whisker plot demonstrate the distribution of the door-to-needle time of all the 14 thrombolyzed patients. With regard to the functional outcome, at 3 months follow-up, 10 patients had modified Barthel index of 15, representing independence with minor assistance, and only 1 patient had moderate to severe disability with the modified Barthel index value of 12. With regard to the occurrence of ICH, 1 patient developed intracranial hemorrhage, which falls under ECAS classification PH2, that is parenchymal hemorrhage, and died before discharge. And we also noted the protocol violation in that patient. And another one who had developed an intracranial hemorrhage, which falls under ECAS classification HI2, was discharged but died before 3 months due to other causes. Other patients were discharged from the hospital within 5 days and with one loss to follow-up. Talking about the mortality with the gathered data, mortality due to intracerebral hemorrhage was 7%, and whereas all-cause mortality was 14%. And this bar diagram compares the on-discharge Barthel index versus 3-month Barthel index of individual patients. And the case number 1 was the one who had ICH and died before discharge. Case number 4 was the patient who had developed an intracranial hemorrhage but discharged and then died before the 3 months review. And case number 6 was the one who lost to follow-up. So in conclusion, from this clinical audit, the door-to-needle time did not reach the standard goal in our stroke care services, as all the patients had more than 60 minutes of door-to-needle time. And with regard to the functional outcome, at 3 months, 70% gain complete independence with the modified Barthel index value of more than 50. So depending on this clinical audit, it clearly demonstrates the need of re-evaluation of the thrombolytic pathway in DGH Monaragala to minimize door-to-needle time and improve clinical outcomes. At the same time, strict protocol adherence is important to reduce complications. So depending on this clinical audit, we have formulated and implemented strategies to minimize door-to-needle time as follows. We restructuring of ETU to function 24/7, and we have arranged several training programs for medical officers as well as the nursing officers. And we have taken steps to minimize door to CT time. We have established a dedicated for telephone line and ETU, so the peripheral hospital doctors can contact the ETU staff prior to transferring patients, so the message is delivered to the CT team. And also, few of the strategies were taken to improve the outcome of the patients as to increase the public awareness and increase the awareness and prompt actions of healthcare workers from periphery in order to minimize the presentation time of the patient. At the same time, we introduced a stroke nurse service to the District General Hospital Monaragala. Thank you.